just wait for some of the attendees to log into the system. It takes a moment or two. So good afternoon to people who are joining us. It's lovely that you're able to be with us this afternoon. Hopefully it's not too cold and snowy where you are and that you're able to keep sufficiently warm. Looking at the numbers, they're still going up a little bit, so I'll give it a couple more moments before we start. Right, I think we'll get going. So thank you very much for joining us, everybody, and welcome to this afternoon's virtual information seminar on Pompe disease. I'm Dr. Kate Adcock. I'm Muscular Dystrophy UK's Director of Research and Innovation. We've a really packed agenda this afternoon with a fantastic array of speakers, and we're going to split the session into two parts. We're going to begin with a look at the latest developments around research into the condition and give a chance for you to ask any questions you might have. And then we'll move on to discuss living with Pompe disease, where we'll focus on answering your questions, as well as covering as many as we can that we've received and that been submitted in advance. We'll be using the Q&A function, which you should be able to see at the bottom of your screen on the Zoom call. So please feel free to type in any question or comment and we'll feed those into the discussion. And to help us manage the technical side of the event, we won't be calling on any questioners to ask their questions directly, so please do use that Q&A function. And any questions we don't manage to cover this afternoon or we don't know the answers to, we'll seek to answer them through our website afterwards. And before we begin, just to note that our helpline is available to anyone affected by muscle wasting conditions. So do please contact us if you have any questions or in need of support. We can either help you directly with information and support you, or we can point you into others where you can also get support from other sources. Just as a reminder for those of you who would like this information, the number and email address should be on the screen now. So do feel free to call us on 0800 652 6352 or email us on info@musculardystrophyuk.org. And finally, just as a reminder, we're recording this session and it will be made available over the next few days through our website and through our YouTube channel. We'd also like to thank our sponsor for today, which is Sanofi. I'm going to be chairing the first part of today's session, and to start us off this afternoon, I'm really delighted to introduce our first speaker, is Dr. Jordi Diaz-Manera. Professor Manera is a professor of neuromuscular disorders at Newcastle University and is a consultant clinical geneticist at the Newcastle Hospital's NHS Foundation Trust. Originally, he trained as a neurologist in Barcelona, and in 2013, he obtained a PhD from the University of Barcelona, where he studied new diagnostic and therapeutic aspects of dyspholianopathies, which are types of limb-girdle muscular dystrophy. Professor Diaz-Manera has interests in a range of neuromuscular conditions, including Duchenne muscular dystrophy, various types of limb-girdle muscular dystrophy, and of course, Pompe disease. His research encompasses both basic research on muscle fibrosis and fat replacement in muscles, and clinical research on the use of magnetic resonance imaging for diagnosis and follow-up of patients. And I'm sure he's going to be talking more about that to us this afternoon. So Jordi, thank you so much for being with us this afternoon. Please feel free to share your screen and over to you.
I was mute. Thank you very much, Kate. Thank you again for giving me the opportunity to present a bit the last research in Pompe disease. So when I was preparing this talk, I was putting a lot of the data that we are also generating in the lab, and then preparing some component that was going to be basic, and then some of the last research that we have obtained from clinical trials, some of clinical research. And then I noticed that I had like 80 or 90 slides, which was too much. So I have decided just to focus this and in more a clinical aspect of the disease. So clinical research that we have some projects that we have collaborated, and also some of the results of clinical trials, because I think that this will open the discussion later. So just to start, I'm sure that this forum doesn't need to be introduced about what is Pompe disease, but just to set a bit the scene. So Pompe disease is a lysosomal disease that is caused by mutations in a gene that is called the GA gene. And this encodes for an enzyme that is called the alpha glucosidase, which is responsible for the degradation or the breakdown of glycogen into glucose inside the lysosome of the cell. So in a healthy person, what is going to happen is that the cell requires energy, and in order to obtain energy, it's gonna use the glucose. So cell will send the glycogen inside the lysosome, and there, this glycogen is going to be metabolized by the enzyme into glucose. So in Pompe disease, the enzyme is not working for different reasons. There is because maybe the enzyme is not even present, or there is a malfunction of the enzyme. Anyway, the result is that we have an accumulation of glycogen inside the lysosome because the cells continue sending this glycogen there. And this is going to lead to a disruption of the cell function in many tissues, but patients will develop symptoms that are mainly related with the dysfunction of the skeletal muscle, the smooth muscle, the heart, and more recently, we're also learning that the neurons of the central and peripheral nervous system can be affected. So there are two classic phenotypes. We talk about infantile onset Pompe disease for these patients that are going to start during the first months of life, and they are going to typically present with hypotonia, so we mean that and general muscle weakness, as the patient that you can see here in this video. As you can see, this patient is not moving too much, and you can see that, for example, has a feeding tube because has some difficulty to swallow. And this patient, the most dangerous thing is that they develop an hypertrophic cardiomyopathy that can lead to early death if they are untreated. And then we have what we call late onset Pompe disease patients. As you can see, one patient here walking with a typical gait of these patients, that it's a more heterogeneous disease. Patients tend to start after the 2 years of life. They can start either when they are adolescents or later in life. Most of the patients will start with symptoms during the 30, 40 years of age. It's in general a slowly progressive disorder affecting skeletal muscles, initially lower limbs and then progressing to upper limbs, and also very important affecting the respiratory muscles, which will produce respiratory insufficiency. So there are different phenotypes that have been described in this disease, but I think that is what I have just explained is the standard patient that we see in clinics. So why we have these two different phenotypes? So there are some reasons. So in patients with infantile onset Pompe disease, they tend to have a type of mutation that is called nonsense, which means that they are not able to produce any enzyme or just very reduced enzyme quantity. So this means that they are not able to process the glycogen at all. And these are the patients that we consider, or we call them CRIN negative, those that do not express at all any enzyme, which are the patients that are more severely affected and respond less to the treatment. Those patients with infantile onset that express a bit of enzyme are called CRIN positive, and this tends to be less affected and respond better to the treatment that we have so far. And if we move to the late onset patients, this tends to have what we call missense mutations, which means that these allow them to produce some enzyme, and therefore this means that they can metabolize the glycogen somehow and obtain some energy from this glycogen. And these are, of course, CRIN positives because it means that they produce some of this enzyme, and then they tend to have this presentation later in life and respond to the treatment, as we will see later, in a better way than some of the CRIN negative, even though the response to the treatment is not complete. So I think that one of the interesting points that have been raised in recent years is the need of neonatal screening in Pompe disease. So as you know, neonatal screening can be something that can be difficult to implement in some countries because there are always discussions about implementing a program for a disease that has no treatment. Sometimes it's not recommended. In the case of Pompe, there is treatment since many years ago, but the reality is that there is not a neonatal screening program in most of the countries. However, there are now some pilot experience in the United States, also in Taiwan, and in some countries in Europe. And what we are learning from these neonatal screening programs is that the prevalence of the disease is higher than what we expected. Now we think that it could be 1 out of every 17 inhabitants. But the reality is that when we look for this amount of patients in our clinics, these are not the numbers that we see. So the reality is that it seems that there is a discrepancy between what the neonatal screening program says and what we see in clinics. And we don't really know why there is this variability. It can happen that there are countries with a high frequency, like for example, Taiwan or the Netherlands, or countries with a very low frequency, where like Finland, where there is not a single patient with Pompe described. Or it can also happen that there are minor forms of the disease that can present without any muscular symptom or very mild muscular symptoms that are not even diagnosed. So I am still the PI of the Spanish registry of Pompe disease, and we have collected data from more than 50 hospitals that have participated in this registry. And in Spain, which is a country with a population of 45 million, there are only 135 patients included in the registry. And we estimate that there will be no more than 200 patients in total, with some differences in the frequency between different regions. So this is one of the topics that is interesting in now, is trying to understand what is the real epidemiology of Pompe disease in different countries. And for example, as far as I know, there is not data about this in the UK, but maybe then we can discuss this in the debate. So, but okay, let's say that we put neonatal screening in place and we start doing this in our patients. So what do we do after the diagnosis? I think that with the infantile Pompe disease is pretty easy, because we know that we need to treat all of them. The sooner the better. And this is something that is well established. The problem is more for those patients where we expect them to develop symptoms when they are adults. It is not really clear how to handle these patients. So when do we need to see these patients in the clinics? Imagine a baby that is completely normal, or a child that is doesn't have any problem at all. Are we supposed to see this patient every 6 months, every year, every 2 years? What tests are we going to do? So this is not very clear, but I think that this paper from Priya Kishnani, who is a researcher specialized in Pompe from Duke University and has experience with neonatal screening, is interesting, because what they have done here is to follow up in clinics patients that were supposed to have late onset Pompe disease. So they were supposed to start with the symptoms late in life, for example, at 20, 30, or 40 years of age. And they have been following them when they were still babies. And what they have observed is that some of them are developing some kind of muscle problems, even when they are very, very young. For example, CK levels can be a bit increased, or for example, they can have some delay in the acquisition of motor milestones. This, in many cases, is a mild delay, but is something that could be identified in these patients. And very interestingly, some of the patients have some difficulties to swallow when they are babies. Or for example, when you explore the posture and the movement of these patients, they have identified that there are some mild changes in the posture that are probably they were not noticed in the Pompe patients before where they were diagnosed. So it seems that this disease, late onset Pompe disease, that we all agree that starts later in life, when most of the patients are 20, 30, 40 years of age, can indeed start earlier, and we can detect some changes in patients when they are babies. So very interesting to see that the phenotype is evolving toward a more wide definition of it. So in terms of the treatment, I think all of you know that we are treating patients with infantile onset Pompe disease since many years ago. We started in 2006 after this clinical trial, where 18 patients were treated at 2 different doses. And the reality is that a study never finished because it was stopped in front of the excellent results that Sanofi obtained with Myozyme. So here they observed that all of the patients treated were alive after 15 months of age, while the natural history of the disease was showing that the patients were dying. And not only that, most of the patients did not require any respiratory support. And when they look at the heart, In all the cases, they identified a reduction in the size of the heart, so the hypertrophic cardiomyopathy. So as I said, the trial ended, and then we started treating patients with infantile onset Pompe disease. So unfortunately, the story is telling us that this is not always a good result. I mean, we can see that the result that we observe in patients with infantile onset Pompe disease is variable. Unfortunately, patients continue dying despite they can survive the first years of life. But if we look at the percentage of patients that are alive after 5 years of age, we can see that in some reports, they say that there is a 50% of death probability. The response is very variable, as you can see here in this picture, where we have some babies that as they grow, they are developing a normal phase, but in other cases, you can see a clear myopathic phase, as for example, this patient in the picture with an H. Patients can also develop scoliosis, can develop difficulties to swallow and require some feeding tubes. And more recently, we are learning that patients can also have some problems of the central nervous system. Not all of them, but a proportion of them with some hearing problems, for example, or some also cognitive delay. So the phenotype is evolving, and I always say that we are talking about now infantile onset Pompe disease version 2.0, because we are learning about the new symptom that these patients can present. And one of the most striking or more popular thing now for research is the involvement of the central nervous system. So the central nervous system in Pompe disease can be involved either in infantile and late onset Pompe patients. In the infantile patients, we know that there are some cognitive issues, as I said, hearing loss, but there is also some structural changes that happen in the brain of some of these patients that can lead to new muscle weakness and spasticity. In the adults, most of the studies have shown that the problems that we see in patients in the brain of the patients are produced by a vascular involvement. So they can have some aneurysm, dolichoectasia, and some changes in the small vessel that can lead to some alteration in the brain of patients that have late onset Pompe disease. So this is a very interesting matter of research. And in recent years, we are looking for markers, biomarkers, that can help us to identify when patients are having involvement of the central nervous system. MRI can be one. Cognitive involvement can be another one, and then you can do also tests. But I would like to show you this work that has been done in collaboration between our group and the group in the Netherlands, where we have studied the presence of these neurofilaments in the cephalorhexid liquid. So neurofilaments are components of the nerves, and when there is a lesion in the nerves of the brain, these neurofilaments are released and can be found either in the cephalorhexid liquid or in the blood. So in this study that we performed is based in observation of having high levels of these neurofilaments in the blood of patients with infantile onset Pompe disease. So this is a group of patients that we followed in Spain when I was still there. Many patients with late onset Pompe, some patients with infantile. We tested the neurofilaments in the blood, and we observed that in the late onset Pompe, we didn't see any difference with the control. But in the infantile, we observed that in 3 cases, we observed high levels of these neurofilaments. And when we did the MRI to these patients, those patients with high levels had also some changes in the brain and had some cognitive problems. So this encouraged us to contact some collaborators. And in collaboration with the Dutch group in the Netherlands, we have collected a larger number of samples, and we have assessed the neurofilaments concentration in the blood. And we have observed, as you can see here, that in Pompe there is an increase in the infantile Pompe patients in the concentration of neurofilaments in the blood, suggesting that in some of them there is an involvement of the central nervous system, that this increase correlates well with the morphological changes in the brain. So the higher the concentration in the blood, the higher the changes in the brain, and also correlate well with the cognitive problems. So the higher the levels of neurofilaments, the worse the cognitive issues that the patients have, suggesting that this is a good biomarker for identifying central nervous system involvement in patients with infantile onset Pompe disease. So I want to put this slide here because we are going to talk now about new potential therapies. And I think it's important to understand what happens in a cell of a patient with Pompe disease. So I have already mentioned that in normal health, the enzyme that is called the GA is produced by the information contained in the gene. This molecule is going to be modified and is going to acquire these residues of mannose 6-phosphate. And this is information for the cell to send this enzyme into the lysosome where it's going to degrade the glycogen. In Pompe, we have a lack of production of this enzyme, and this means that we have this accumulation of glycogen that is going to be inside the lysosome. Some lysosomes are going to just explode and release the lysosome to the cell. But it also will hamper the normal function of the lysosome, which is related with the removal of old organelles and protein, and this will produce accumulation of what we call autophagic vacuoles in the cell, and this will lead to cell dysfunction. So if we want to treat patients with new therapies, we have different options. One of the options that I would like to mention first is the ERT. As you know, ERT is enzymatic replacement therapy. I have already mentioned the study that was done with myozyme in patients, in infantile patients. And do you know that myozyme is the standard for care for both infantile and also late onset Pompe disease? But there are some companies that are trying to identify new ERTs. And what they try to do is to modify the existing molecule and have a molecule that can enter better into the cells of the patients. So we have two different drugs that have arrived now to the market. One of them is avalglucosidase alpha, also called Nexviazyme, that has been developed by Sanofi. And this is a molecule that is based in the old myozyme, but that has a higher levels of mannose 6-phosphate residues in the surface, so allowing the drug to be recognized easily by the cells and arriving easily to the lysosome. And this drug has demonstrated to be more effective in removing glycogen from the muscles of mice with the disease, which has launched, of course, a clinical development in clinical trials. So there are many trials that have been done with this drug. And today I'm going to focus in two trials, the Mini Comet, which is a trial done in infantile onset Pompe patients, and also the Comet study. So let's talk a bit about the Mini Comet. So the Mini Comet is a study. It's a phase it's a phase 3 clinical trial that has been done in patients with infantile onset Pompe disease that included many different arms of patients that had the diagnosis of the disease and received different doses of the drug. Just to make a story short, I want to show you some of the results that have been published so far. So what we have seen with this drug is that all patients improve. And this is measured with, well, all patients, most of the patients improve. And this is measured with different scales, like a scale that are going to measure the cognitive and the motor development, and also a scale that are going to measure the muscle strength. And patients have been followed in this first data for 25 weeks, but now we have data from for a long period, 97 weeks, that are showing that patients are stable in their motor function, as you can see here in this graphic, that they can also have a reduction in the size of the heart, and then also have a reduction in the markers of muscle damage in the blood and in urine. And in general, the data is that the Sanofi has is showing that there is an initial improvement in most of the patients, as you can see here in this graph, and that after a while the patients remain stable. So the other good news is that the treatment seems to be safe, and because there had not been severe adverse effects and almost no severe effects in this population. So if we move now to the adults, well, the response to the treatment, we all know that is in general good. We can say that patients tend to have a good response to the treatment during the first months after the treatment is started. After that, patients will enter into a kind of a plateau. And the bad news is that we know that after this plateau that can last for 2-3 years, patients will start a very slowly progressive deterioration. And the reality is that after 10 years of treatment, the data that we have show that 50% of the patients will have a decline in respiratory and motor function compared with the onset of the treatment, while the other 50% can still have some kind of improvement or retain some kind of improvement compared to the onset of treatment. This data comes from some open label studies. So this means patients that have been seen in hospitals, and we doctors have collected the data in our centers. And these studies have been done in the Netherlands, but also in Spain. We have recently collected the data from patients in the registry that is showing, as you can see, a decline in the 6 minutes, the distance covered and the 6 minutes walking test, and also in the forced vital capacity in the patients that were registered after some years of treatment. So in front of this situation, of course, we need new treatments. And the COMET study is a phase 3 clinical trial that has been done in patients with late onset Pompe disease. And in this case, patients included were patients that were naive to the treatment, which I think is very important. So patients that never received any kind of treatment, that were diagnosed with late onset, so means that the symptoms started after the age of 3 years of age. And these patients have been followed now for at least 145 weeks, so we have long-term data. And what is the data that we have? As I said, in the first phase of the study, the study was designed to compare myozyme with a new drug, Nexviazyme, and patients were followed for 49 weeks. And after this period, all patients start receiving the new treatment, Nexviazyme. And I'm going to show you the data, the more recent data that we have after 145 weeks of follow-up. So this data is showing the following. If you look here in blue, you will always see patients that received Nexviazyme. In gold, you can see the patients that received the myozyme, and then they changed it to Nexviazyme. So initially, we observed an improvement in the respiratory function. This was measured with the forced vital capacity, so with an spirometry. And you can see that the improvement was observed in both arms, but was superior in the arm of Nexviazyme. And then we arrived to a plateau, and the plateau was very soon arrived. The reality is that after 13 weeks, we did not observe more improvement in our patients. And after these 145 weeks, we could see that this improvement is maintained. So after this period, we still see some benefit in the forced vital capacity in our patients. And this is supported by similar results in other respiratory measures like the MIP and MEP, that are going to look at the inspiratory and expiratory capacity of the patients. If we look to the motor function, we observe similar results. As you can see here, improvement in the distance that patients were covered with the 6 minutes walking test. The differences, the distance was higher for the patients in Nexviazyme than the patients in myozyme. And when switched, what we have is a stabilization, which is a surprising data, to be honest, because we don't see further improvement in the patient that received the new drug, but suggests that the drug is able to maintain at least the benefit obtained after the treatment. And these good results with 6 minutes walking test were supported by other similar results in the muscle strength, measured with a dynamometer, as you can see here, improvement in both arms, and then a stability. And also in the quick motor function test, which is a test that combines different tests and also time tests for the patients. And you can see here again, improvement and then a stabilization. So this is not the only drug that has been tested now. We have another drug that is called glucosidase. And this is a combined treatment. So it's an enzyme that is given to the patients that are going to also take another drug that is called the chaperone. And the chaperone is going to extend the half-life of the glucosidase in the blood, allowing the muscle to uptake more drug from the bloodstream. And this combination of drugs have demonstrated to be effective also in animal models, where you can see that this combination reduced the glycogen, which are these kind of dots inside the muscle fibers, compared to the vehicle, so the animal that was not treated. And therefore, of course, the company Amicus that was developing this drug moved this into clinical trials. There have been different clinical trials. I just want to present the data of the Propel, which is a phase 3 clinical trial that included patients with late onset Pompe disease. So in this case, patients were two different types. We had patients that were naive, so that never received any treatment, or patients that were experienced, so they were already treated with myozyme. So the company decided to include all patients in the same group and treat them comparing CIPA, so their treatment, with myozyme for 52 weeks. And after these 52 weeks, patients were entering into the open label extension. So what are the results that they obtained? So the results are the ones that you can see here. If we start with the naive, the results are showing that their drug, which is a new drug, has demonstrated to improve the distance that patients can walk, as you can see here in blue, at a similar level than myosin. And the reality is that after switching all patients to the new drug, we have not seen further improvement. It seems that the drug stabilizes this function, as we have seen with Nexviazyme. If we look at the respiratory changes, what we have observed is that despite the treatment, in this study, patients worsen and worsen at a similar level without difference between the two treatments, which is an interesting result because it's the first time that we see a worsening in forced vital capacity with any treatment. Although I want to just let you know that this data come from a very reduced number of patients. As you can see here, only 22 patients finished the study for 104 weeks. If we move to the experience patients, we have seen that it seems that CIPA have a better results in terms of the distance covered than the 6-minute walking test. As you can see, after 52 weeks, patients in CIPA were covering a longer distance compared to those in myosin. And after switching, as happened with Nexviazyme, we have not seen any further improvement. So it seems that the drug is stabilizing the patient after that. And what happened with the respiratory function? So in the patients treated with CIPA, we observe a stabilization of the forced vital capacity, while in patients with myosin, we observe an initial worsening that stopped after patients were switched to CIPA glucosidase, and then a stabilization. So what is the data that we have from real world? And I want to stop here for a second. We can then discuss this in the debate, but I think it is very important that in front of the data that we have from the trial, which for me is good data supporting that the drug works, but it's very difficult to say if the drug is better than another one. I would say that we need to rely in real world data. So it is important that all doctors that see patients in our country with Pompe collect information about the response to the treatment. So we know that in England and Wales, there are patients now that are treated with the new drug, with Nexviazyme and CIPA glucosidase. As you can see here, there are already 20 patients that have switched, the infantile patients that have switched from myosin to ABA. So there are some patients now that have switched. And in the case of late onset, there are also patients that have switched to ABA and also CIPA glucosidase. And what are the recommendations that I can give? So this is based in my opinion. It's nothing that is based in any medical guidelines, which means that is wrong. So we should do some discussion based in medical guidelines and research. And the reality is that there are not medical guidelines there on how to apply the new drugs that are arriving to the market. And maybe when you go to the doctor and you are introduced to these drugs, it is difficult to tell you which drug we should use. In personal experience is that I have not seen any side effects in switching, which is good. So far I can say that it seems that switching from one drug to another one is safe, which of course is the most important thing. My recommendation for a de novo patient, so patient that is naive, based in the data, we can say that there are no differences between CIPA glucosidase and myosin, but there are some differences between aval glucosidase and myosin, suggesting that the later drug can be superior. Of course, we don't have any comparison between CIPA and ABA to say that CIPA or ABA is better than the other when given to a patient that is de novo. In a patient that is already treated. So for the patients that are worsening, we know that there are two new potential options, which is good, of course, because we mean that a patient that is experiencing a worsening in his or her medical condition can be treated with something new. In a patient that is stable, is switching necessary? I don't know. That's a reality. So I think that if we would have long-term data suggesting that these drugs are really able to maintain the stability in the disease, I would probably say that yes, we need to switch the patient to the new drugs. But the reality is that long-term data that we have just come from, as you have seen, a handful of patients, and it's not enough to say that these drugs are for sure going to keep the muscle function of the patient for 5, 6, or 10 years. So as I said, we need to collect this data and we need to develop clinical guidance. I want just to use the final part of my talk to introduce you to new treatments that are arriving. So you see here that a part of doing ERT, we can also try to reduce the production of glycogen. So the cell is going to produce glycogen using an enzyme that is called glycogen synthase. And this is going to produce glycogen from glucose, where we store the glucose in our muscle fibers. So there have been some research in the last years trying to identify drugs that can inhibit the function of glycogen synthase. So we have two types of glycogen synthase, one that is expressed only in the liver, which is glycogen synthase type 2, and another one that is expressed in the muscle, the heart, and also in other organs, and this glycogen synthase type 1. So Mace Therapeutic, which is a company that has developed different drugs in order to find one that was able to reduce glycogen synthase function. And they identify a product that was able to reduce this in animal models. So you can see here the result that they got. This is what is called SRT. And when they were given this drug to the animals, they were able to reduce the amount of glycogen in the Pompe animals. These are the long bar is the animals that are not treated. And what they observed is that the combination of ERT with myosin and their drug was the most effective in reducing glycogen in the muscle, the diaphragm, and the heart. So they also studied what happened in patients that had a reduction in the expression of this gene naturally, and they observed that they did not have any problem in muscle function. So suggesting that reducing this enzyme activity could be safe and could be helpful for patients. So in theory, MACE was going to start a phase 1/2 clinical trial, and this is still being planned. But just for you to know that Sanofi is now trying to acquire mice therapeutics. The process has not finished, although I know that Sanofi has also confirmed that if they are able to finally buy this company, they will continue with the development of this drug. And then I'm not going to talk too much about gene therapy, but just to let you know that there are some gene therapy programs in Pompe. One of the programs is trying to bring a healthy copy of the gene to the skeletal muscle and the heart, and this is the clinical trial called Fortis, which is done by Astellas Therapeutics. And there are two other trials that are trying to bring a healthy copy of the gene to the liver in order to that the liver becomes like a pump that produces the enzyme that is released to the blood and where it's taken by the muscle. So just to finish with two comments on the protocol that we are doing here, as you see, all the studies are trying to reduce glycogen. And we are very interested in trying to measure glycogen in the muscle in a non-invasive way. So there are different ways of doing that, and we are interested in this technology that is called carbon spectroscopy. So carbon spectroscopy is an MRI method, a muscle magnetic resonance imaging method, that what will do is that it's going to develop a spectrum of all the atoms of carbon that are present in the muscle. And then we can see these different peaks here. The big peak is the fat, and this small peak here is the glycogen. So we can detect glycogen in the muscles using this MRI. And it's interesting that in the animal models, when the animal models were treated with a gene therapy, this MRI was useful to detect a reduction in the levels of glycogen in the muscle. So there are not many protocols to do carbon spectroscopy. So we have developed a protocol to do it in a 3 Teslas MRI, which are the conventional MRI that are present in the hospitals. This is the coil that we have developed in our center. It's a handmade coil that we have done here. And what we are doing is that we are doing this MRI in patients with Pompe, and we are obtaining this kind of a spectra here, identifying the peak, and we are measuring that. So in the protocol that we are comparing the glycogen levels in patients with Pompe and patients with controls, doing this MRI. But we are also doing a set of muscle function tests to identify the muscle function of the patient and correlate this with the levels of glycogen. And we are also collecting blood samples for this for biomarkers. So this is a study that is still open. If you are interested in participating, I will show you my email, and you just need to contact me, and we can try to enroll you in this study. And just to show you the preliminary results, we have so far 6 patients with Pompe that have been tested here, and we have been able to successfully identify their glycogen levels, and we have observed that the glycogen levels can be sometimes increased compared to controls, although we still need much more data to have a final result about this methodology. So this was my last slide. I just want to thank you for all your attention. And also, this is the team in Newcastle. This is my email. As I said before, you are interested in knowing more about the research that we do in the lab. I'm sorry, just please contact me. And that's it. Thank you very much for your attention.
Jordi, thank you so much. That was fantastic and really great kind of discussion of the condition, how the disease starts, what causes it, and the various different treatment options that are available and the clinical trials. So an amazing tour de force. Thank you so much. If anyone has any questions, do feel free to add them into the Q&A. You mentioned a few things that I might take my prerogative as chairing for this session to pick up with you on, if that's okay with you, Jordi. First of all, you talked about the differences in the numbers of people with either the infantile or the late onset presentation of Pompe disease, and you showed the sort of the different, dare I say, sort of lumpiness of the numbers across Spain, and then you sort of said about the difference between Netherlands, and there's no one recorded in Finland. So if we were to sort of take those examples and sort of transpose that to the UK, what do you see could be the challenge of trying to find the numbers of people in the UK who have Pompe disease?
Oh, that's a very good question. So, Kate, I think that the main limitation here is that there is not an UK registry. So the registry of Pompe that we have in the UK is what is called the Sanofi Pompe registry, and this is a registry that was started by Sanofi many years ago when they launched the treatment, and it's an international registry that contains data of patients from many different countries in the world. This registry was not set up in Spain, and that was the reason why we set up a registry there when I was still working there. So in the UK, maybe I'm wrong, but Rina can please correct me if I'm wrong. As far as I know, there is not a registry where we can do an epidemiological study or at least have an idea of the number of patients that we have. Of course, the companies that are providing the treatment and the payer, which is NHS England, can know how many patients are that are receiving the treatment at least. But it's difficult to say how many patients in total are there. Of course, if we are interested in doing that, one of the things that we could do is to ask Sanofi to provide the data that they have, and we will have an estimation. And then the good thing about Pompe is that most of the patients are seen in treating center, in specialized centers. We could also try to collect the data from the patients that are seen there. We will know that this is not going to be perfect because probably some patients will not be collected, but at least we will have an estimation of the numbers in the UK.
Through the chat function, actually, John, who I know will be introduced to later on, but he's from Wales, and he mentioned that there are regions of Wales where there are no patients sort of listed, registered, whatever, as having Pompe. And I mean, that could also be due to difficulties in diagnosis as well, that people may actually not have yet received a diagnosis of Pompe. They may have something else, or just undiagnosed muscle condition, I suppose, as well, which is also a challenge.
Yes, of course, this is the reality of many patients with Pompe and other neuromuscular diseases. So just to put here some things on the table. So Sanofi has done an incredible effort to facilitate the diagnosis of patients. So in many different countries, for example, they are funding programs to do the enzymatic activity study in the blood spots, paying the study, so facilitating it. But having said that, it is true that even though if you have a suspicion of a patient with Pompe in front of you, or someone that has hypercycemia or have muscle weakness, and you could do this diagnostic test easily, it is not. We are missing patients because sometimes the most important thing is that the doctor that is seeing this patient to remember that there is a disease called Pompe. The diagnosis of Pompe is not difficult. I mean, once you have the clinical suspicion, the diagnosis is relatively easy in most of the patients. There are, of course, some patients where it can be more complex, but if you have suspicion, you can do the enzymatic activity in blood, or you can do the genetic analysis, muscle biopsies, MRI. So there's a lot of literature about how to diagnose the disease. For me, the most difficult thing is that you need is thinking in, there is a disease that is called Pompe, which is extremely important because this is a disease that has a treatment. So if we don't diagnose the patients, these patients can progress without being treated. And the other point that you mentioned, of course, I would like to know the opinion of the other panelists here, but the other point that you mentioned here is that can also happen that patients do not develop many symptoms. And for example, if we look at patients that start when they are very old, so more than 60 or 70 years, which is not very old, of course, but it's older than other patients. Sometimes they have mild symptoms, or they have had mild symptoms for ages, like some difficulties in walking, and they are not diagnosed until they develop a respiratory insufficiency. So they require ventilation, and then that is what triggers the diagnosis. But if you ask the patient carefully, they have been complaining about a funny way of walking or back pain for some years or even a decade, and without sometimes going to the doctor. So it can happen that we have also mild spectrum, a mild severity patients that just present late in life, and we are missing some of them. I see that John has put here something interesting, that in the UK, we only diagnose one patient for 434,000 inhabitants, which compared to the epidemiologic studies in the Netherlands or in some regions in the United States, it's very low, right? So I think that there are, of course, some genetic differences as well between the UK and these other populations, right?
Yeah. Dr. Sharma, do ask your question. I love this. We will introduce all the rest of the panelists later, but panelists, please do feel free to jump in. So, Rina.
Am I allowed to ask questions, Kate?
Please do.
Yeah, thank you for that. So there are a couple of things I would like to mention. I think, where this about the frequency, how come we got so little patients, and I fully agree with Jody that a lot of patients, it's amazing how much they put up with in their life before they actually seek medical help. And the disease is gradual. Things keep gradually happening, and they just put on with it. Till something happens catastrophically, either a respiratory failure or something, and that's how they come to diagnosis. But I have recently seen 2-3 patients who I'm sure have been suffering from symptoms for last 10 years or more. But it was not till now they actually sought medical help. So it was not even the diagnosis was missed. They didn't even go to a doctor. So I think it's very important to understand that these are subtle changes that keep happening, and rather than blaming it on your having children for women or having a busy life with, it's not just that, there is more to it. So I think these patients going to the doctors a bit sooner will also help to diagnose these undiagnosed patients, which I'm sure there are a lot in the community which we haven't diagnosed. And I think that's very, very important. The question for you, Jody, that I have is, we talked about, changing from the existing treatment to the neurotherapies. How do you deal with the new diagnosed patients and which therapy to put on? Is there a way you decide that, or?
That's a good question, Rina. So as you know, as well as me, that there is not a right or wrong here. So what can I say? I think the reality is that we have now 3 drugs. I don't think that I would not start myosin in the new patient, because we have new drug that the results that we have the long-term result that we have suggest that they can be more effective in maintaining the muscle condition. Mm-hmm. And then I would start with one of them. So the reality is that with the naive patients, ABA seems to be superior to myosin, and CIPA doesn't seem to be superior to myosin. So if we just say this, I would probably say, let's start ABA. But the reality is that we don't have enough data to support this. I think that we need much more data from patients that are naive, because we cannot, based on the publications that we have so far, we have seen that both treatments improve patients, which is good, of course. So both treatments work. But saying that one is better than the other, just based in the clinical trials that have been done with 2 different populations, You know, that because we cannot say that the population that was included in the COMET is comparable to the population that was included in the PROPEL. So for me, it's very hard. I think that the message is, oh, let's say the ball is now in our field. So we need to collect this data. That should be the message. No matter what you do, no matter if you start with FIPA and myosin, but we need to collect the data from the patients that we start the treatment or the patients that we switch. And we do need to do it in a collaborative way, because it's not just for us in order to have the data and publish. It's mainly for the patients, because the patients deserve that we have a clear idea of what is the best treatment, or if there is a treatment that can be dangerous, or that the two treatments are the same, because maybe what happens is that the treatments are the same. Having said that, just I want to mention something before Nick comments. So what we know with CIPA is that we need to stop the treatment if patients get pregnant, which is an important point. So you have a woman that starts with the disease and wants to have children, I don't think that starting CIPA is the best option, for example. This is something that we need also to consider in our decision, because it is that the company does not have enough data to support continuing the treatment in a patient that is pregnant. This is one thing. And the second thing is also that, and I should have it, but if we start the treatment or change the treatment, we should have some guidelines about how to follow our patients. For how long are we going to keep the treatment? Because I come from a field where myasthenia gravis, where we have a lot of immunosuppressors that we can give the patients. That happens several times, that you see patients that have been treated with a drug for 1 month, and then another drug for 3 months, and then another drug 1 month, and that you don't really have any data on, is this drug useful or not. So if we switch now to a new drug, I think that we need to keep the treatment at least 2 years before switching to a different one.
Thank you. Yeah, I was going to ask a question around the switching and monitoring, but Nick, you have a question, so please, over to you, or a comment.
Yeah, thanks, Jorge. That was really interesting. I know you said about collaborative data and sort of doing longitudinal studies, but what do you want us to collect as physiotherapists? Because as far as I'm aware, there's no standardized assessment tool out there for Pompe. So do we make use of what we've got? And if we're going to do that, we need to then make sure we're collecting the same data across all the sites so that we can then analyze the data. I know I saw on the Newcastle that you're developing an outcome measure. Is that right? Using RASH?
Yeah.
So would we be expected to do 6-minute walk test? What would be the minimum sort of data set that you'd like us to collect, in other words?
Thank you, Nick. So I think that we need to continue collecting what is the standard measures, which is a spirometry, so forced vital capacity for sure, sitting and lying. If you can do MIP-MEP, perfect. If you cannot do it, no problem. I think that at least the forced vital capacity, sitting and lying is important. And then in terms of motor function, 6 minutes walking test for sure. I think this is, and the main reason is because this is what is used in the standard way in all the trials, and having this information is still relevant. But I agree with you that we probably need to move into new ways of measuring muscle function. So, for example, we are trying to validate this scale that is called NSAD, which is the North Star Assessment for Dysphalanopathy, that is used in patients with limb-girdle muscular dystrophy, and seems to be very good in order to catch muscle weakness that is affecting the proximal muscle, which is what happens in Pompe. So NSAD should be okay. If you are interested, I can put you in contact with Meredith James, who has developed this scale. But I probably think that we need to go for other time tests, for example, the time to up and go, the clean for steps. And then I would probably go for daily life activities like the air-packed or the active limb. So this is my suggestion. But I think that what we need here is to set up a collaborative program where we all collect the same. And it's not Jordi Diaz or Nick Emery suggestion. It's something that is shared and we agreed. And just to announce that, for example, with Sanofi now, we are working in having a guidelines in the UK for starting and following up, starting the treatment, how to do the monitoring of the patients. And then these are going to be just guidelines that are going to be agreed between specialists, including physios. But I think that is an important document to ensure that we collect the data in a standardized way. And I do think that the treating centers will need to collaborate.
Sorry, I was just jotting that down. I'm sorry, I forgot I've got to talk as well. Nick, you have another question?
Well, it's not really a question. It's just that, I mean, we haven't got really, it's very difficult for us to do 6-minute walk tests. But we use the NSAID for our limb girdle, but also for our FSHD. Would it be worth just doing the limit of the sort of ceiling effect with a pull if they were the weaker patient, because it gives you quite nice quantitative data, but I don't want to sort of like add something in that's not going to be useful.
No, I think it's going to be useful. So pull is useful because, as you know, the upper limbs function is something that is not very well covered within SID, and having the pull would be fantastic. The problem is how many centers can do the pull. So because you need the table we can regulate the table, as you know, and there are some centers like your center or here in Newcastle where we have all the devices that we need, all the equipment. But I think the pull is more complex. Of course, if we can do it, yes, let's do it. The 6 minutes, you said that we cannot do it. Well, if you cannot do it, I probably will do at least the time to water meters, because this is it's included in the NSAID and give us an idea of what is the distance the patient, well, not the distance, the time that the patient needs to reach that distance, right?
I'm mindful of time, but there is a question that's come in through the Q&A function, so thank you for that. And one of the participants that's joined us online has said that they've just started treatment with Nexviazyme, and will their medical information and hopefully their progress be automatically captured for the experts? So for people like you, Jordi, or does he need to do something so that you can be able to analyze his data? What do you suggest?
That's the problem. So that always, unfortunately, very often happens that we are not ready when the treatments are available. And the reality is that we should set up a collaborative project where we collect the data of our patients prospectively. So in most of the cases, in most of the hospital, patients are seen by physios like Nick that can collect the data. And if the data is available in the forms or in the notes of the patients in the folder, we can recover this data later. But the direct answer is no. We don't still have any program or collaborative project between all the centers to collect the data of our patients. The positive thing is that I guess that today this talk will help to encourage others like Rina, for example, or Patrick, also Nick, to start collecting the data in a collaborative way from the patients that we see.
Fantastic. Thank you.
I think one thing is very clear that, like we can add, as you said, Nick, more sophisticated tests for, monitoring. But I think we have to still stick to what has been measured in the trial, so that when we can actually relate to that, because we are basing our decisions based on the trial. So at least we can carry on doing that, which will be 6-minute walk and, lung function tests the way they have been done, plus anything that we can add to it, whether it's activity of daily living, Rotterdam scale, or other things that we can add to that.
Brilliant. Thank you. There was one other question from John, which we'll just touch on briefly, and then I will hand over, because we could talk all afternoon, but we do have a panel, and it would be lovely to introduce you properly rather than just me bringing you into the conversation. So just one quick question then, Jordi, and then I will end this part of the session. But there's a question around if the general decline for people with the disease is around sort of 7 years, how important is it to sort of start treatment immediately, or is there a sort of a sweet spot, really, I suppose, the best time to start treatment?
Okay, just to clarify here. So what this decline after 5, 6, 7 years is observed in patients that have already started treatment.
Oh, I see.
So it's not that a patient that is naive will start having problems after 7 years of life. So this is very variable. As I said, there are some patients that can start with symptoms when they are teenagers, others that will start disease when they are much older. For the patients treated, and then also let me clarify this. For patients treated with myozyme, the results of the group shows that as a group, we see a decline in their motor function in after the range of 5 to 7 years of the treatment. But this is as a group. If we go to the individual levels, there are some patients that are stable after 7 or 10 years of treatment, while there are others that start the decline 1 or 2 years after myozyme. So this is very variable and needs to go case by case. So all the decisions about changing any treatment needs to be taken case by case. And I do think that based in now we are talking about switching, of course, based on the patient situation. If the patient is stable, is there a need to switch? We can discuss. This is open, as I said, not right or wrong here. If the patient is worsening, there is a need to switch. I would say yes. Let's try something new.
Okay, fantastic. Thank you so much. So Geordie and John, Rena and Nick also, thank you all so much for your contribution to this session. It's been absolutely fantastic and fascinating, and we will make sure that we will add your, if you're happy, Geordie, your email address is clear to people when we post the video, so that they can contact you around the clinical trial and being involved in clinical studies, if that's okay. So
yeah, that's
thank
okay.
you so much.
Thank you very much.
And now, thank you. I will hand over to Jackie, who will lead us through the rest of the afternoon. So thanks, Jackie, over to you.
Thanks, Kate. So hi, everyone. So we'll now move on to a session about living with Pompe disease. So I'm Jackie Monroe, Head of Regional Support Outreach and Information at Muscular Dystrophy UK. And I'm really delighted to welcome our 5 panellists today, who will be joining Professor Diaz-Manera and will help us to discuss and answer your questions. So today we're being joined by Dr. Patrick Murphy, Val Buxton, Nick Emery, Dr. Reena Sharma and John Foxwell. So I'll go on to introduce each speaker and just then invite each of them to make a few remarks about their experience of supporting people living with Pompe disease and to raise some key points about managing or living with the condition. So as Kate mentioned at the beginning of the seminar, we'll be covering as many questions as we can that have been submitted in advance. And we'll also be using the Q&A function, which you should be able to see at the bottom of your screen. So please type your question or your comment and we'll feed them into the discussion. And any questions we don't manage to cover or don't know the answers to, we'll seek to answer directly after the seminar. So I'm really pleased to introduce our first panellist today, so Dr. Patrick Murphy. So Dr. Murphy was appointed as consultant at the Lane Fox Respiratory Unit, Guy's in St Thomas Hospital in 2014 and was appointed clinical lead for the service in 2020. Completed a PhD studying respiratory physiology and acute and chronic respiratory failure, secondary to COPD and obesity, and was appointed a reader in respiratory medicine at King's College London in 2019. Dr. Murphy's research interests involve respiratory physiology and respiratory support in acute and chronic respiratory failure. If I could just hand over to you, Dr. Murphy, just to say a bit about your experience of supporting people living with Pompe disease and any kind of key points around managing the condition.
Jackie, well, thanks very much for the introduction, and Prof. Jordi for the great talk that we've all just seen on the drug treatments around Pompe disease. So my background, as you said, is around respiratory support and particularly non-invasive ventilation and respiratory failure. So as we discussed, the 2 big domains that are affected by patients with Pompe disease are either the peripheral muscle function or their respiratory muscle function. And so very much I'm focused on supporting those who develop respiratory insufficiency. As was outlined in the talk earlier, that quite often some of the peripheral muscle features can be relatively mild and patients can present predominantly with a profound respiratory muscle weakness and respiratory failure, and that's the mode of diagnosis for a small number of patients. So our role in the care of patients with Pompe disease is in those patients who are diagnosed with peripheral muscle weakness. Sometimes we're involved in the surveillance of their respiratory muscles, so performing regular measurements in terms of spirometry that was discussed or other measures of respiratory muscle function to try and detect prior to the development of respiratory failure when they might need respiratory support, so that we can open a conversation about how they introduce and start non-invasive ventilation. Unfortunately, a lot of patients we see with Pompe disease, as with a number of other neurological disorders, or neuromuscular disorders rather, present with respiratory failure. So the first time they are coming to our services when they're already needing respiratory support. Sometimes that's as part of an acute hospital admission that's needed intensive care. So they're coming to us from, in a very unwell condition, needing to be transitioned to a respiratory support device that they can then take home, having previously been managing in the community without any respiratory support. So we provide that respiratory support device, and then from that point on, we follow the patient up to maintain the correct settings on the device, help support with use, and monitor the change again in those respiratory muscles so that we can better match the level of respiratory support to the need of the patient over time.
It's great, thank you very much. I know that we do have some questions around respiratory management for Pompe, so I will introduce the rest of the panels and then I'll come back to some questions at the end, if that's okay. So I'll just move on to introduce Nick Emery, who's joined us today as well. So Nick hasn't always been a physiotherapist. He started his career as a Royal Marine Commando and then spent 18 years in the London Fire Service. Nick then qualified in 2005 as a physiotherapist and started work at the Neuromuscular Centre in Winsford in July of the same year. He then moved to the Robert Jones and Agnes Hunt Orthopaedic Hospital in 2009 and works with a fantastic team. So the team that Nick's currently part of looks after approximately 1,200 patients, both paediatric and adults. And Nick's not only involved in clinical work, but also has a role in both pharmaceutical and clinical interventional research. Nick, if it's okay, can I just hand over to you to speak more about your role as a neuromuscular clinical specialist physiotherapist in relation to supporting people with Pompe disease?
Yeah, thanks, Jackie. I think my role is very much the immediate management of the patient, both in terms of physiotherapy and making sure that they maintain as much functional ability as they can, and that might include provision of exercise or referral to other colleagues for orthotics. And I think it's also trying to be predictive about how the patient's going to be in 6 months' time or a year's time. So that would be looking at the respiratory function and then referring on to our respiratory colleagues earlier rather than later, and also making sure that they have access to other areas of the team, and that might be to do with they might need housing, or they might need support with benefits or mobility aids or vehicle adaptations, access to wheelchairs. So it's not just about sort of looking after their physiotherapy in terms of muscle function and doing assessments, but it's looking after them as a whole person and also their wider family as well.
So I'll just introduce Dr. Reena Sharma now. So Dr. Reena Sharma is a consultant in adult metabolic medicine at Salford Royal Hospital in Manchester. Dr. Sharma is responsible for looking after adult patients with rare genetic metabolic diseases and for providing clinics and inpatient management. Dr. Sharma is also an investigator for clinical trials and has undergraduate and postgraduate teaching responsibilities. Dr. Sharma, if it's okay, can I just hand over to you to speak about your role in supporting patients with Pompe disease?
Thank you, Jackie, for that nice introduction. So yes, so I work at Salford Royal Hospital, which is one of the biggest unit in the country, I think, for the rare diseases in adults. And in our care, we have got about approximately 50 adult late onset Pompe disease patients and a very few pediatric patients as well, or infantile Pompe disease patients who got transitioned from the children's hospital. And my role is actually mainly for patients who are referred for suspected diagnosis of Pompe to confirm the diagnosis, or patients who have been referred with a confirmed diagnosis to make a management plan and how do we go forward. So I see patients, as a diagnosed or undiagnosed patient, and then have a discussion with the patients, make a joint decision with the patient what kind of ERT they should go on, how should they go on, and also may support them to become independent with this enzyme replacement therapy, which is a big burden on them. It's a long-term treatment. So that's like the key role. But as a part of that, we have got a physiotherapist, same as Nick, who does all the job that Nick has kind of mentioned here, and my role becomes more monitoring to make sure their lung functions are measured, their assessments are done, and whether they are responding, not responding. Do we need to change therapy? Do we need to change some way of managing them? And the way I see it, Pompe is actually a multi-organ disease or multi-system disease. So, Jody mentioned about neurological involvement, but you also see like gastrointestinal involvement. Patient can start losing weight. They get gastroparesis, so that can also happen. They can also, some of them can also have cardiac involvement. So my approach to these patients is a very holistic approach, supporting them with the living with that, and also manage each and every symptom that comes up, and how do we do it more appropriately.
Thank you very much, Dr. Sharma. And as I said previously, we do have some questions, so I'll come back to them once I've introduced everybody. So I'm really pleased to introduce John Foxwell today. So John is an award-winning educational author, publisher and software designer. As a professional writer, John's had his work translated into over 20 languages. He specialises in educational text in plurilingual settings. He's worked in education at all senior levels within schools and local authorities, building schools for the future and academies, and with government departments for over 20 years. So John is living with Pompe disease and is currently working to promote awareness of the condition through lectures and talks with medical staff at hospitals and within university settings, whilst undertaking unique research into awareness and diagnosis. So John, can I hand over to you to share your experience about living with Pompe disease and any key points around supporting others who are also living with this condition?
Of course, yeah. Pompe is one of those really odd conditions that affects everything. And the big thing for me is that most people aren't aware of the symptoms. We talk about Pompe, we talk about symptoms, but no one ever identified what the symptoms were. And to me, that was one of the big things when I started, was I wanted to know what the symptoms of Pompe were. So I contacted medical professionals from around the world, the Pompe family, the Pompe community on Facebook, and I got them to send me the list of the Pompe symptoms they had. And in the end, we created a list which has got the majority of the Pompe symptoms on. So it's easy for doctors to identify. So when I work with hospitals, consultants, new doctors, etc., then the big thing is to show them the whole list of symptoms that Pompe can present with. And if we do this, we find that all of a sudden they start thinking about, well, I've got somebody with that, or I've got somebody that shows this, and it makes them think about it. So for me, making people aware of Pompe was making people aware of the symptoms initially, and then talking to them how easy it was to start diagnosis. And the Sanofi testing kit that every doctor can access quickly was great for me, because it meant I could take the pack into the hospital with me or into the talk with me, and actually give some out. Obviously, they couldn't use the ones I gave out, but they could. They had a physical representation of what it was, and to me, that's important. Working in education for most of my life has meant that it's about the easiest way to get information from one person to another, and to make the most impact for them. So that's what I've done, really. So that's me.
Thank you very much, John. And it'd be great to hear more about, and I know that you've been involved with Pompe Wales as well, so it'd be great to hear more about that just shortly. So finally, I'll just introduce Val Buxton, who's joining us today. So Val is the CEO of AGSD UK. Val has a background in nursing and public health and has worked in a range of health and voluntary sector roles, with a particular focus on community involvement and tackling health inequalities. So Val, I know you've got some slides to share with us today just about the support available from AGSD UK. Are you happy to do that? Sorry, you're just muted there.
That's great. I'll just bring up the slides if that's okay. So hopefully with you in a second. On a little go slow here. Can people see that coming up?
No, sorry, it's not come up yet.
Don't you love technology? It's showing that I can share screen. It's showing the icon, but the selected file. Oh, there we go. Here we are.
There we go. We can see that now.
Lovely. So, and hopefully we'll be able to see it in slide mode now. Yeah, is that okay?
It's not in slideshow mode just yet, but it might just be taking a couple of minutes to catch up.
Yeah, I think it is on a go slow. But anyway, just to say that I was just quickly going to run through a few slides about what AGSD UK can offer people affected by Pompe alongside other community organisations like MD UK. And has that come up at all now?
So we can see the slides. It's just not on presentation.
All right. So sorry, I'll keep going, and hopefully it will catch up with us. So our mission at AGSD UK is to help everyone affected by any GSD to live positively with the condition. And our current strategy is built around 3 themes, which are support across the community, help with living well, and better treatments and service access. And those were based on the things that people affected said would have the most impact on their lives with the condition through a community listening exercise. And for each of these, we've got measurable goals and actions to achieve them. And in that listening exercise, people really expressed just how important it is to be able to talk to others who were affected. So connected people through our online and in-person activities and get-togethers and our volunteer coordinators is absolutely central to what we do. When we know that living with rare conditions like Pompe and other GSDs can feel incredibly isolating, and hopefully you might be able to see, if you have got the full screen mode, that from these quotes that people who joined our community socials over the last year or so expressed how much they valued being able to talk to somebody who genuinely understands while not having to explain their condition or feel like the odd one out. Our next social get-together is a festive one, and that's coming up soon online on the 9th of December. So it would be great to see people on this call there. And we'll also be aiming for an in-person Pompe get-together in the spring of next year.
Val,
yeah.
Sorry to interrupt you. From where we're looking at it, your slides haven't moved
Have they
forward.
not
We're
moved
still
on?
on the first slide.
Thank you so much for that. So
there we go.
Yeah, I'll go back to
now.
Yeah, I'll go back to not trying to do it on full screen mode. So sorry about that. So that was the goals. This was the support across the community, where people were saying just how good it was not to have to explain their condition and to have things in common with people in the room. And then I was just going to go on to talk about our main events, which have an important part in connecting people and delivering support across the community. But they also contribute to our other goals, like equipping people with strategies to help with living well and providing updates on latest research. And again, I'm not sure if you'll be able to read it in this mode, but these are just a few quotes from the feedback that we had from our main event earlier this year, where people talked about how they appreciated the chance to exchange tips and experiences and find ways to optimize their health and hear from leading experts. And we'll be aiming to host another in-person weekend later next year. So just moving on, again, one of the popular things from that event was the opportunity to try some new therapeutic activities such as art and music, which form part of the living well aspect of our programme. And actually from tomorrow at 7 o'clock, we'll be starting an online wellbeing group, so people can come together virtually to try out a range of activities to support relaxation and emotional well-being. And again, it would be wonderful if people on this call were able to join us. And we're also working with community members to develop an online self-management programme focused on people who are more recently diagnosed, really aiming to help people come to terms with the condition and access the information and support that's available, exploring approaches to living well. And that's due to start in late spring next year. So it's just a couple of quotes there highlighting how important that early support is for people. Another way that we provide information is through our regular Glisten magazine, and we're also working to update and expand our publications and the information available on our website, really focusing on practical and accessible resources to help with living well. And then a really crucial part of our service is actually the help with rights and benefits that's offered by our specialist care and welfare advisors, who are pictured here. They've got a really good success rate in securing the financial support that people are entitled to and helping people with their rights, for example, in relation to employment and disability discrimination. Again, there's just a few quotes here highlighting the difference that this can make for community members and how essential it is to feel that there's somebody actually on your side. So that's illustrated again in relation to the work that the team does to help people navigate services, where they regularly help achieve outcomes like enhanced social care packages and education and healthcare plans, and help people get access to other services like community transport and home adaptations. And then this last slide is really just about the way that AGSD UK and other organisations like MD UK can support research towards better treatments and services by promoting research opportunities, building evidence about the impact of the condition and the needs of people affected, and facilitating your community input into study design and materials, as well as sharing, of course, information about the latest research. So I hope that's just given a flavour of what AGSD UK has to offer to individuals and families affected by Pompe. And there are also lots of ways to get involved and help shape our activities and have a voice. So please just contact info@agsd.org.uk for more information. And that includes about those events and activities coming up tomorrow and on the 9th of December, when you can get joining instructions from that email address. So thanks for that.
Thanks very much, Val. And you'd mentioned during your presentation there about the specialist care advisor. Can people self-refer into that, or would it be via?
Absolutely. If you just go via that info@agsd.org.uk address, you'll get put in touch with them, or there are telephone details as well on our website.
That's great. Thank you very much. So I'll just go through. So we did have some advanced questions that were submitted to us just before the seminar. So I'll kind of just go through them if that's okay. So we did have a couple of respiratory questions, Dr. Murphy. So one of the questions that we had, so we're aware about Pompe disease impacting on the muscles that control breathing. So just as we're coming into the winter months, is there any advice around that we can share with people in terms of the importance of early detection and management of respiratory complications?
Yeah, so a really important question, as you say, topical now and as we go into winter. What we'd say is, one, patients with Pompe where there's concerns about respiratory disease should have a respiratory assessment. Patients with respiratory failure or significant respiratory muscle weakness are at greater risk, and they need additional support to try and help them through that time, and should be managed. Those patients who have established respiratory failure may also have the breathing muscles are used to get the air in and out of the lungs, but they're also used to generate cough and clear secretions from airways, and therefore cough function can be impaired in patients with Pompe disease as well. And if you have impaired cough function, then chest infections can be incredibly dangerous and worrying, and may require additional support. And for a minority of patients, they require a device called a cough assist, which helps perform some of that function. Now, for patients with milder disease who are at risk but maybe don't have established respiratory failure or profound respiratory muscle weakness, we'd suggest that probably the things that all of us should do to try and keep healthy over the winter, and that's be sensible about who you see and when you see. So if you have contacts who have who are unwell and have a respiratory disease, actually it's sensible to avoid contact with them over that period. Be sensible about those contacts, particularly with younger children as well, who are more likely to be carrying respiratory viruses. Get vaccinated. The flu vaccine campaign is well up and running, and patients with Pompe disease would be eligible for the flu vaccine, and should ensure that they're on the list with their GP to get that annually. Similarly, the COVID vaccine, and none of us need to talk in depth about the problems that COVID has given over the last couple of years, and the ability for us to have moved forward in the last 18 months, 2 years, is because of that vaccination program. And anyone who's vulnerable should, I'd very much encourage to get vaccinated and ensure they're fully protected as best they can. There's a third vaccine, the pneumovax or pneumonia vaccine, that some patients will be eligible for as well, and they can be assessed for that if they've not already had it. Keeping yourself generally healthy, so actually good diet, good exercise. There's a reasonable amount of data as well that if you, it sounds like a bit of an old wives' tale, but actually if you let yourself get cold, you're more likely to get a virus, and that's probably because and they did that experiment actually by getting a small group of healthy volunteers to either sit with their feet in cold water or their feet not in cold water, and actually there was a statistical difference between the numbers who got respiratory infections over the days that followed. So it sounds a bit like an old wives' tale, but actually wrapping up warm and being sensible about these things actually does add some benefits as well. The other thing, and it was alluded to in all of these, is that we can all ignore symptoms sometimes, but again, it's just being vigilant. Well, if you start to develop those symptoms, actually, be cognizant of getting help, thinking about an assessment from your GP or another healthcare professional. For those patients with established respiratory problems, having a rescue pack of antibiotics that they can start promptly if they need to, and they're all sensible strategies.
Thank you very much. We had another question about people who may be experiencing sleep disruption or sleep disordered breathing. So would the symptoms of sleep disordered breathing be apparent, or are there certain things or warning signs that people should be aware of if that hasn't been picked up?
So another really good question. That all of our breathing is a little bit worse when we sleep, and that's to do with the normal physiological changes. So it's a really good stress for the respiratory system, and so therefore people who might, when we see them in clinic, all of their parameters may seem normal, or they may have some mild features of respiratory muscle weakness. Actually, sleep can bring out that problem and make it really apparent. And therefore, it's a good chance for us to assess and pick up early patients who are at that risk. Because if your body can't manage with the insult of sleep, actually, if you do get that respiratory infection, you're really likely to decompensate and struggle. Now, the problem is that the symptoms of sleep disorder breathing can be quite generic. So poor quality sleep, waking feeling unrefreshed, waking with a headache in the morning, being sleepy during the day or falling asleep when you don't want to. They can all be features of sleep disorder breathing. Also, they're quite often features of sort of modern life and sleep restriction and other things. So people can often, as they do with other symptoms, ignore them. So it's being aware that they could be something else and getting checked. The other feature that maybe people would be less likely to ignore, but you can get swelling of the ankles if your oxygen levels are going low overnight, putting a bit of extra stress on the heart, and that again would be something people should be aware of to prompt early intervention. But home sleep studies are readily available now for us to assess patients, and so it should be really quick if you're worried about sleep disorder breathing from Pompe to get an assessment and make sure that that's not the case.
That's great, thank you so much. Nick, you've raised your hand.
Far be it from me to tell Dr. Murphy his job, but also the change in the sleeping pattern. So you can ask the patient, have you changed the number of pillows you're using? So are they sitting up more to sleep? That can also be an indicator of that they're struggling a little bit overnight. Just to throw that in there, sorry.
No, very much so. People buying new mattresses is another one that we've had that people try lots of things to improve their sleep, and often don't attribute it to a health problem. So any of those changes, that's a very good point, Nick.
Thanks. And Nick, I was actually just going to come to you next, because there's a question in the Q&A that I think you might be able to answer. So if it's okay to answer this question, is Pompe different from other muscular dystrophy types for exercise advice? And are there any books or anything else that would help with ensuring a good diet?
Is it any different? Every single dystrophy or muscle disease is different from the others. So what we probably would find is that there's lack of evidence for all types of exercise in neuromuscular conditions. It's not great. But what I would say is that exercise is going to be good for everyone with a muscle condition. It's just the intensity and how long you do it and the type you do. So I always advocate sort of aerobic exercise. So the exercise bike or just floor pedals, some gentle walking. They can go to the gym. You just got to be careful that the weight you're using don't put excess stress on the muscle, because if you're going to damage the muscle, is it going to repair itself? Don't know. Although with Pompe, it's a energy production problem, but that still leads to potential damage within the muscle. So I think that if people are going to do some exercise, it's probably worth getting some advice from their specialist physio prior to just embarking on something. But I would advocate gentle aerobic exercise and gradually build it up. Don't go mad. And if you get, my advice is a little bit of fatigue when you're exercising is perfectly acceptable. Any pain during or after exercise, you've probably done a little bit too much, but you probably haven't damaged your muscles, but that gives you that indication that that's too much for you. And your exercise tolerance and intensity and duration can vary from day to day. So don't expect you to be able to do 10 minutes on one day and be able to do 10 minutes the other day. It might be better off doing a day on, day off, day on, day off. But as I say, it is difficult to actually be very prescriptive with exercise. It's going to be different from every single person you see with Pompe or any muscle condition.
Thanks, Nick. The other part to that question, just to any of the panelists that can advise, was around any resources or books or information that would help with ensuring a good diet. I know that's a question that we get through quite often around nutrition and diet and things like that. We usually kind of signpost to more specialist services in terms of kind of dietitians and things like that. But if anyone's got any resources that they're aware of that we could share with people.
John, think there's any sorry, John. I was going to say, I don't think there's any specific resources, but I think having a well-balanced diet is going to be the best way to go. Whether having a slightly restricted carbohydrate diet would be of benefit, I don't know, because of the carbohydrate. Georgie's shaking his head there. So I think just having a well-balanced diet with your little bit of I'll have a treat occasionally, it's not every day.
That's great. Thanks, Nick. So John, you came off mute there as well. Have you got something that...
Yeah, sorry. The 3 years ago, we looked at diets and how important it was to have low carb, low sugar, high protein diets. And so we worked with a nutritionist to create something called Eat Well, which is a recipe book or an eating well book designed for people with Pompe, because it covers the majority of things they need, simple recipes that can be used, but it's nutritionally based. And that's available through the AGSD. The Pompe support team created it with the AGSD support.
That's great, John. Thank you very much. So Nick, there was a couple other questions, if that's okay. So one of them you've kind of answered just in your last response, but someone's asked, what are the main benefits of physiotherapy for someone who's living with Pompe disease, and could physiotherapy assist with reducing the risk of falls and managing fatigue?
Yeah, I think if you're seeing someone who understands the condition, definitely. But if you're seeing, and no disrespect to the general physiotherapists out there, it's a rare condition. And if you went along there and said, I've got this now, I'm struggling with, they might just prescribe exercise to try and make you stronger. And that's maybe detrimental. As I said, I think just doing general exercise would be beneficial, but certainly going to a specialist centre with specialist physiotherapy care would enable you to access the orthotics team. And if you've got a very good orthotics department, those who supply splints to help with foot drop or to help with giving you a little bit more stability when you're walking, I think that's probably the best option.
Thanks, Nick. Dr. Sharma, your hand up.
Yeah, I'm just going to add to Nick what you very eloquently described. That doing too much can be detrimental. And I'm just going to give an example of a patient whom I saw recently, and she wanted to lose weight, and she started doing, and this was before the diagnosis. She did lots of walks, hiking, mountain climbing, and she very clearly said it actually made her weaker. She should have felt better, but it made her weaker. And that's a very clear example that, if you overdo it, it can actually make your muscles weaker.
Yeah. Thanks. And Nick, you kind of mentioned this in terms of accessing physiotherapy where you can speak with someone who has a good understanding of the condition. But someone's asked where can they access physiotherapy that's tailored to their needs, and would it be something that they can access regularly? And I know that's a bit of a challenging question because that can differ depending on what area you live in and what you have access to as well.
Yeah, I think that if you're going to access sort of a specialist centre, the best place to go is MD UK, because they have all the addresses at all the centres. So that would be the place I would go. And if you're coming to a specialist centre for access to physiotherapy, my role is not necessarily to provide physiotherapy on a weekly basis. I'm more a triage service, so I'll assess you and not decide, but suggest you go to various other departments or specialists for their care. But having said that, we will also advise on levels of activity or other interventions that might help support you achieve the most you can with your condition.
Thanks. I know within our team, we usually advise people to speak with their kind of neurologist as a lead consultant to find out what specialist services are available to them. But if not as well, what we always find as well is that specialist neuromuscular physiotherapists are usually really happy to work with community-based physiotherapists as well, just to pass on that kind of expert knowledge too.
Yeah, but so as John said, it's that awareness of the diagnosis, and some patients will go to their GP and then be referred to physiotherapy and without the diagnosis, and that's where the issue might arise. And I'll give you an example. We spoke to a patient the other day who has got FSHD, facioscapulohumeral muscular dystrophy, and she went to see a physiotherapist, and he said to her, "I've done my research, it only affects your face and shoulders, it doesn't affect your legs." And she was extremely weak around her pelvic girdle and lower limbs. And she was adamant, "Well, it does, because I can't get up. I'm really struggling to get up." And he said, "Oh, no, it doesn't affect you in that way." So there's still a huge amount of education we need to do for the wider community. But we're a small services, and we haven't got the time or the resource to actually spread the word.
Mm-hmm. We hear quite often after people have been in hospital for a period of time as well, that quite often the focus could be on rehabilitation. And there's not always that kind of understanding that muscles might have become deconditioned, and people have, that the rehabilitation of those muscles aren't always a possibility as well. Thanks for that.
Sorry, again, it's like, if you have a fall and you got Pompe and you get a fracture and you go into hospital, the condition follows you in, and then the physiotherapists and the rest of the team are like very wary about going anywhere near you because they don't understand it. So I have quite a few calls and conversations with hospital physios about, yes, you can, but you've got to do this or that. So it is having that communication. It's also about the patient's awareness and having a good team around them. They know they can contact the team.
Yeah.
Can I just say that Newcastle University did a fabulous course on falls awareness, which looked at why people fall and how to avoid it. And we've actually turned that into a booklet that's available through the AGSD, and it looks at things like the height of your walking stick, if you're using a walking stick, your types of shoes, your eyesight, lots of little bits like that. But there's actually a booklet on there and a full video that actually shows people how to get up off the floor, etc., if they do fall. But there is a full program available through Newcastle University.
That's great. Yeah,
really good.
I've heard of kind of referrals to falls clinics in other areas as well. I think it's just that joining up the specialist knowledge sometimes as well, if it's a more kind of general approach to falls prevention. Dr. Sharma, I was wondering if I could ask you some questions that came through, if that's okay. So someone's asked, so that they know that there's different types of Pompe disease and that quite often the heart may be affected. Is that more prevalent in certain types of Pompe disease? So, for example, would that impact more in children than adults, or vice versa?
So the infantile Pompe disease, which Jordi very kindly mentioned earlier, has got a heart involvement. That's very, very common, one of the important feature of infantile onset Pompe disease. But in the late onset Pompe disease, it's not a regular phenomenon. But I do have patients who have got some kind of heart involvement. So something I always keep my mind open about, and if need be, do the investigations that's related to that and refer to the right team. So one patient has required a pacemaker, one has got recently found to have a cardiac hypertrophy. So, and there are a few others as well. So I think, it is something that can happen, and we have to keep our eyes open, but not so prevalent in adult as it is a very, a key feature in the infantile Pompe disease.
Thank you. And I think Geordie may have touched on this earlier in his presentation as well, but I'll just ask again. So with regards to the late onset type of Pompe disease, is there an average age or stage in which Pompe disease may be diagnosed, or could diagnosis be at any age within adulthood? And I know that challenges around diagnosis might impact on that as well.
So yes, well, I think that patients can be diagnosed at any age. In general, we can diagnose patients when they are symptomatic, so when they start having muscle weakness. But we also diagnose patients when they have just hypercyclemia. And these are patients that are asymptomatic, that they don't have any symptom, but that for any reason they have had a blood analysis and the levels of CK are higher. So I don't think that there is a specific age when we diagnose patients. So patients with late onset Pompe disease can present at any age.
Thank you.
And just to clarify, so you can have a diagnosis of late onset, let's say in age 3, 5, or 6, as early as that, or as late as age 75. So we have got patients, from all age group who got diagnosed at any time in, late onset after the infancy is, first 2 years have passed.
So actually, the late onset word is a bit misleading because it seems that it's going to be late in life and doesn't, and then for sometimes people have tried to use the adult onset, which is again misleading because we can have also children that are 10 years old, and then we are started using the juvenile onset, which makes everything a mess. So the reality is that we now use late onset Pompe disease, but just to clarify, as Rina said, it can be from children to 3, 4, 5 years to someone that is 85.
I think probably the better description will be infantile and non-infantile.
Yeah, it's a good.
So that may be a better way to describe rather than late. So you can infantile and non-infantile, that covers everything else. So that may be a better way to describe them. And just to kind of point out, so tonight on Channel 5 there is a documentary on cause of death, and that Pompe, late onset Pompe, is actually covered in that. So John, when you're talking about how to make people aware of the symptoms, so I think if people who are watching on the joined up in the cast today, if they would like to join there, that they would see something about Pompe there as well.
Thank you very much for sharing that. So there was just another question around, so we've already spoke about how diagnosis can be challenging and things like that, but have you seen, in terms of awareness of the condition becoming more prevalent, have you seen any improvement in terms of diagnosis? Are the numbers increasing? Has it been picked up earlier?
I think there's definitely an improvement. So, I have been working in this field for last 15 years now. So initially, from first the patient goes to a clinician, it will take 2 to 3 years before a diagnosis is made. But now the clinicians are a lot aware, so it doesn't take that long. So that time has certainly gone down. I think what is not happened yet is the general population being aware of it. So that hasn't kind of gone into the mainstream yet. And as the more people are aware, they'll be, going to the, clinicians much earlier. But I think there's definitely a reduction in time to the diagnosis once they seek medical help. And hopefully this program tonight will help, increase the awareness of the condition in general population.
Thank you very much. John, that kind of brings me nicely on to you, because one of the questions I wanted to ask you was, based on your experience and the awareness raising that you do, is there any advice that you could give in terms of actions that people living with Pompe disease could take to raise awareness of the condition, either with medical professionals or with interested communities?
I always tell people that if they take the symptoms list to their doctor, it raises awareness, because all of a sudden they're aware that there are more issues to look at, because the first thing they say is, oh, it's to do with your walking, or it's to do with your breathing. But Pompe affects everything. I didn't realize until I was talking to Sanofi about a year back that it actually affects being able to cross your eyes, because it's a muscle weakness, and any muscle in your body can be affected by it. And that was a big thing for me, was what happens and which muscles are affected by it. But the more you look into it, the more you realize it's every muscle can be affected by it, but not for everyone. My big thing with Pompe Wales when I created it was the fact that if you had an accident, the first thing they want to do is to lie me down and give me oxygen. Great. The first thing that's going to kill me is lying me down and give me oxygen. Because the minute I lie down, I start breathing. The minute you give me oxygen, it shuts down my breathing. And so I want to create medical alert pages that could be given to an ambulance crew straight away. And so we have key rings with a QR code on that can be scanned by any mobile phone, and up it will pop and tell you things not to do for Pompe. And I'd like to that was one of the big things for us, was trying to save lives, because we don't want people being diagnosed on the autopsy table. Because at one point, they said it was the biggest diagnosis reason for Pompe was on the autopsy table. And I think if we've gone past that now, we need to make more people aware.
Thank you very much, John. And I was going to ask about Pompe Wales as well. I just wondered if you could tell us a bit about Pompe Wales and how it came to be and what the aim of Pompe Wales is. Sorry, John, you're on mute there.
The speech went funny, I couldn't hear you.
Oh, sorry, I was just asking about Pompe Wales. I was just wondering if you could tell us a bit about Pompe Wales and how it came to be and what the aim of it is.
In Wales, we're very territorial. And I found that if it was Pompe UK, it would be detracting from other organisations that were promoting Pompe. So I thought, we'll stick it to Wales. I know Wales, it's a relatively, as I say, territorial area. When I put Pompe Wales, all of a sudden people logged on. People in Wales logged on. And it's that thing about keeping it local and personal. Because I think illnesses like Pompe are very personal. You need somebody to talk to that listens, that understands, and understands the limitations within Wales that we've got. Yeah. Because we haven't got the biggest hospitals, we haven't got the biggest systems, and everything's so far spread out. So I'm the only person in my health board that has Pompe, which causes great fun when I go anywhere, because first thing I have to do is explain Pompe to everybody. But I say, which is why we created the symptoms list, and why we've worked with things like the AGSD to create other booklets that we could use, because they had the funding, and that's proved really good. And so we have a group of people around the UK now that actually offer support to people with Pompe. So when somebody's diagnosed with Pompe, they can contact any of us, the Pompe support team, and we'll sit down with them and talk through their issues and just get over the initial fear, because it's frightening. You look on Google and all of a sudden I'm dead. I should have been dead 5 years ago, because I think it says you die after 5 years, and it becomes all this drama. And the reality is, when I was diagnosed with Pompe, I went to one of the AGSD conferences, which was superb, and I met people with Pompe, and that to me made me create Pompe Wales, because it made me think, well, other people will need somebody to talk to, and that's what we do. We just talk to people. We make people aware that we care, and that it's not going to kill them. It might make life a little bit more difficult, but with new treatments and with careful management, you can live with Pompe to a ripe old age.
Thanks very much, John. I think that access to that local tailored support is so important as well. Being able to speak to people who have an understanding of what's available in their own community and in their own region and things like that sometimes just goes towards people feeling a bit less isolated when it's a rare condition as well.
Yeah, we have a lot of mums that ring up when their children have got it, and we're not talking children as in like 10 years old or 5 years old. We're talking children like 20. We got a young man the other week that had just finished his A-levels, and then late onset Pompe really kicked in with his bowels, and he was scared to leave the house. And so we were talking to him about how we can maintain education and what help he could get. And I believe now he's booking a university place, and we're just managing it carefully. But it was quite good. And to get him to talk to people, because he didn't want to talk about these issues, we actually linked him up with Vicky, who was a great gamer. And they linked up on Call of Duty and had this conversation over chat. Yeah. It was a different way of doing it, but you've got to be able to reach the people that need it at the level they need it at.
Yeah, absolutely. Thank you very much, everyone, for answering those questions. Unfortunately, that's the end of today's session. I'd just really like to thank all our panellists and the people who helped to guide the discussions with very good questions and comments. So you can see recordings of all our other seminar sessions on our website, and the recording of this session will be posted there later this week. We'll also be in touch with a very short survey to gather some feedback on the session, which will be invaluable as it shapes how we do these seminars in the future. So just a reminder, our virtual information seminars are a source of information, but shouldn't replace direct advice from your own specialist consultant or health professionals. So if you do have any concerns, we always advise to speak with your own neuromuscular clinical team or health professionals directly. Thank you very much for joining us, everyone, and thanks again to all our panellists.
Thank you. Thank you, Jackie.
Thank you.
Thank you very much.
Thanks, Jackie.
Bye.